Welcome to the Speaking of Women's Health podcast. I am your host, Dr. Holly Thacker. I'm the Executive Director of National Speaking of Women's Health. And thanks for joining us back in the Sunflower House. This is a special edition and episode of our CME podcast. And this is being sponsored by a grant by Astellas and Bayer in conjunction with Rush University, Plexus Communication, Advancing Health After Hysterectomy, and our nonprofit Speaking of Women's Health. You can find out about more information about this CME program and other upcoming podcast episodes on menopauselearning.com. Joining us this episode is the incredible, wonderful Dr. Phil Sarrel. I count Dr. Sarrel as a very close friend and mentor. Dr. Sarrel, he's currently Emeritus Professor of Obstetrics and Gynecology, Reproductive Sciences, and Psychiatry at Yale University School of Medicine in New Haven, Connecticut. He was appointed to the Yale faculty in 1969, and he's remained at Yale throughout his career, rising to the rank of full professor in 1988. After receiving his bachelor degree from Dartmouth College in New Hampshire and his medical degree from New York University School of Medicine in New York, Dr. Sarrel completed his internship at the Mount Sinai Hospital in New York and his residency in obstetrics and gynecology at the Yale New Haven Medical Center in New Haven, Connecticut. Dr. Sarrel is the author or co-author of over 200 medical articles and book chapters for medical textbooks. And he's also the co-author of 6 textbooks specifically related to menopause and to understanding sexual behavior and sexual response. He is the founder and president of the Advancing Health After Hysterectomy, also known as AHA, like I get it, Foundation. It's an organization that focuses on educating women, their doctors, their nurses, the media, educating them that in any woman who's had a hysterectomy, who's 60 or under, which totals a whopping 15 million women in the United States alone, should strongly be considering estrogen. Thank you so much for joining us, Dr. Phil Sarrel. Welcome.
Well, Dr. Thacker, thank you very much for your kind words and for including me in your program. It's so important what you're doing to bring this level of education to the doctors out there who have been missed over the last 10 to 20 years in terms of education about menopause. I think the program you've put together and the speakers you've gathered to present this are really a sterling group, and I hope the listeners will stay with it all the way through the program. And I'm sure it will make for better changes in their practices.
Dr. Sarrel, can you please tell us about AHA? Why did you decide to start this, and what are some of the positive outcomes from starting this very important group, which I am very blessed and privileged to be a part of?
The starting point for AHA is easy to pinpoint. It's the publication in the year 2011 of a WHI paper in which they separated out the women who, in terms of long-term follow-up and effects on cardiovascular function and a host of things, including osteoporosis and hip fracture. The first author is Andrea Lacroix, but the rest of the WHI team is included. And in turning to their tables, you could see the difference between ages of women and when they were given estrogen versus placebo. And it jumps out at you. My goodness, the women in the WHI study who were age 50 to 59, who'd had a hysterectomy and just were put in the estrogen only, these women are showing reduced risks for an array of medical problems and a decrease in mortality. What happened next was we took the number that they gave in that paper and that was that in the years of study, the women who had received estrogen had a reduced risk of dying of 13 per 10,000 women versus the women who got placebo. Well,
Mm-hmm.
that's a figure you can run with, because in going to an epidemiology team at Yale, we were able to put together the percent of women who had stopped using estrogen after hysterectomy since 2002, with the finding that if they had used estrogen, it would have prevented mortality in 13 out of 10,000. Well, guess what that added up to, given the size of the population, which you've just cited? Um, it added up to almost 50,000 women
Mm-hmm.
who died between 2002 and 2011 because they hadn't taken estrogen, compared to before 2002, when over 90% of women after hysterectomy had been using estrogen therapy. Well, we've also extended that, although we haven't published the most recent findings, because the problem doesn't end in 2011, although
Right.
Lacroix's paper should have put an end to the not giving estrogen to women after hysterectomy. It continues for the next 10 years. There were at least another 50,000 women who have died. Most of the women, 11 of the 13, have died of a heart attack. And of those who have died, remember, this is WHI data, their follow-up is such that we know that all those women who died of a heart attack because they got placebo instead of estrogen died before the age of 70. That's unacceptable. And there's
Yes.
any number of prominent women, I've been tracking this for a decade now, whose lives were cut short in their 50s, 60s, at the height of their careers, when they could have been, the head of this company, or the president of this bank, or outstanding writer. Their careers were cut short just in the period of time. Age 50 to 70 can be the most productive period in a woman's life. These women lost out because of this unwarranted fear of taking estrogen.
And we still have this today. I see women refer to me with no medical problems at all, hysterectomy, and their local OBGYN or local primary care doctor won't give them estrogen or refill their estrogen.
I know. And if you come up to date with, by the way, that paper about the calculation of 50,000 deaths was in the American Journal of Public Health. So it's easily accessible for anyone who would like to read it. And it's in 2014. Well, what that led me to do was to gather together a group of thought leaders in menopause, such as yourself, and form the Advancing Health After Hysterectomy Foundation, a nonprofit women's health educational foundation here in Connecticut. And for the next 9 years, we have been holding symposia for women and doctors, sponsored programs like last year's program, in which we collaborated with many people from the Cleveland Clinic to provide a year-long CME program. So some pretty outstanding things have happened beyond what we could have imagined. Right now, I think we're at a turning point. And the reason I say that is, number one, the WHI investigators themselves have come out strongly in favor of estrogen for women who are, certainly women who are 50 or younger, to be given estrogen at the time of hysterectomy and continued for 10 years if possible. And the reason is, those are the women who present with the most severe symptoms, and we can talk about the symptoms, but they're the ones who are most affected in their everyday life. And they're the women who are working. Remember, the half of all hysterectomies are done before age 45. And by the age of 50, 1/3 of women in the United States have had a hysterectomy. Well, estrogen for those women can be life-saving. The WHI data, 20-year data, shows a statistically significant reduction if you received estrogen, reduction in the risk of dying, all-cause mortality, a significantly reduced risk of dying of heart disease, hip fracture, and dementia. Very important to understand the mechanisms of how estrogen helps prevent dementia. And there are some outstanding works, including a paper that just came out from Scripps Institute in December on the mechanism through which estrogen prevents destruction of neurons. It's a landmark
Yes.
study by the leading research group on dementia in the world. And they pinned down the role of estrogen in the modulation, the control of nitric oxide release is critical to preventing the development of molecules that destroy neurons. And that's only one of the actions of estrogen. See, we're not taught a lot about estrogen in medical school. We're taught, obviously it's a steroid, it's related to a lot of other hormones. What we're not taught is it's the first of the steroids. Everything else came, perhaps 100 million years after estrogen. But the foundation was laid down. The basic actions in the body that estrogen has were there 600 million years ago. And you see it in the octopus, which has not changed in 600 million years. And it has to do with the control of nitric oxide release, controlling the levels of catecholamines, very important to an octopus to be able to react to danger and release catecholamines. As long as it's got its estrogen, it's okay. On the other hand, after giving birth to children, and it goes into a severe downcline and dies without its estrogen. And then, so there's a third that the clinician should be made aware of. And those are the studies showing that estrogen throughout the body is a calcium channel inhibitor. It blocks calcium channels. So think of those three major actions in all of our bodies, men and women. Control of catecholamines, nitric oxide, and calcium. What more could you ask of a steroid? We should be taught about that at length in medical school, and we're not.
That's true. And I teach medical students, residents, and fellows, and many of them don't even realize that males have estradiol, and males don't lose their estradiol like women do at midlife because testosterone is converted to estradiol, and the importance on bone health and physiology and vasculature, etc.
That's a really important point because the male levels average around 50 pgs per ml. That's telling us something else in terms of what level does it take to maintain stable nitric oxide production, calcium transfer, the control of catecholamines. But men, do develop hot flashes in their 60s. I can attest to that. As soon as your testosterone starts to decline, and it does by the time men are 62 years old, their testosterones are low. And they develop hot flashes. Even gynecologists, even professors of gynecology. So, for sure, it's an interesting issue. Not just, maybe it's important to emphasize something about the men, and that'll help get more attention to caring for the women.
Well, and men that have to become hypogonadal for treatments of prostate cancer. I'm wondering if the candy neuron antagonists are going to be a helpful role in males who have hot flashes. Of course, that's not what we've covered.
Well, that's a really important point because I heard your discussion with Dr. Minkin about that. And the control of hot flashes is very important because what you're controlling is catecholamines. And if you do that, then remember that women, well, let's go to Rebecca Thurston's work in which she shows how women with severe hot flashes are losing bone, are having changes in the neurons in their brain. That's perfectly consistent with the Scripps study. So they're having neurons being destroyed during the hot flashes. And then finally, there's the issue in what's happening with nitric oxide release. And now there's a whole series of papers. Ours happens to be the first, way back in the 1990s, showing the role of estradiol in inducing nitric oxide to keep coronary arteries open. Well, if you lose that, then you're going to have more problems. So the issue is women with severe hot flashes have nitric oxide depleted. They have real problems with catecholamines. And as a result, you start to see more calcium in their arteries. All of this has been demonstrated, a lot of it by Thurston and her co-workers.
Yes, and of course, Howard Hodis has done great research in the area of cardiovascular disease and women.
Well, especially about coronary arteries and calcium and its relationship. But yes, I think there's a lot to know. There was a recent article about menopause, which is an excellent article. But when the author was asked yesterday on one of the radio shows in New York about hot flashes, her answer was, we don't know much about hot flashes. We know a great deal about hot flashes. There are entire books about hot flashes, the mechanism, the fact that 20% of the blood in your body gets shunted to your skin during a hot flush. Think of what it means to have 20% of all the blood in your body suddenly appear in your skin. Yeah, your skin gets hot, but what happens to the rest of your body? Arteries constrict, it has all sorts of other effects. So we've been studying hot flashes intensively for 50 years. But the bottom line is new treatments that will control hot flashes are also protecting bone, protecting the arteries, protecting the brain.
We'll be back after a quick break.
Hey, quick question for you. Are you someone who wants to be fit, healthy, and happy? And what if I told you you could get your dream body by simply just listening to a podcast? I'm Josh.
And I'm KG, and we are the hosts of the Fit, Healthy, and Happy podcast.
Listen, we get it. Fitness isn't easy. Carbs, no carbs.
Just stop, okay? It doesn't have to be that complicated. And that's why we made this podcast. We get straight to the facts so you can become your best you.
So the way to check us out is click the link in the show notes or search Fit, Healthy, and Happy podcast on any of the major podcast platforms. We'll see you soon.
The nitric oxide link, I'm glad that it's finally getting more awareness amongst cardiologists. I think I got one of my first cardiology consults from a cardiologist referring a woman to me for estrogen who had microvascular angina, not responsive to any nitrates. And they sent her to me, hysterectomized woman, for estrogen.
Well, let's stay with that for a moment because there's a whole series, there's an entire book. It's called Syndrome X. In the cardiology literature. There's an entire book about Syndrome X, and it's mostly women, 90% of patients with Syndrome X. This is the presence of severe angina with an exercise tolerance test that does show ischemia. So the woman winds up with an angiogram, and you know how much that costs. That's a lot of money. And then it turns out she has normal arteries. Well, those women don't respond to nitric oxide, to trinitrate, to under the tongue pills, but they do respond to estrogen replacement. So in paper after paper after paper, this was work that I did with a research team in cardiology in London in the 1990s. We have almost 50 papers in the cardiology literature, and this is an important focus of those papers. And those women are easy to treat, just not with the routine cardiology medications. You need to not only give them estradiol, but maintain stable levels. And what we did find, which I think is an important finding, is we could only accomplish that with estradiol patches. That with oral estradiols, they would wear off even in the course of a day. And so we wound up giving women oral estradiol, BID. That was okay in terms of the arteries, but in terms of everyday maintenance and compliance, that's another issue. That's where the patches have a big advantage.
Well, that's when I met you. I was presenting a patch study in women with migraine. It was a double-blind placebo crossover study of using a once-a-week estrogen progesterone patch versus oral estrogen progesterone. And what I found wasn't what I thought. I found that the oral did better in terms of not having migraine exacerbations. And you told me and you looked at the work and you said, well, you picked the wrong patch. You picked a once a week patch, not the twice a week patch. Everyone knows the levels go down at day 7. And so that certainly stuck with me. I know patients for ease like the once a week patch, but definitely with some patients, some patches, some skin adherence, some generics, not everybody can always maintain the full level up to day 7. So we many times do need to go to a every 84-hour patch.
See, I felt so confident about what I was saying to you because we had a neurogynecology clinic at Yale for almost a decade. All of the patients were women, and they all had some kind of condition related to the menstrual cycle, migraine being the most common. And what we found using transcranial Doppler and measuring the middle cerebral artery blood flow, that there was a consistent pattern with the decline in estradiol. So we had measures of their function when they had no headache, and then we had the women coming in the middle of these terrible headaches, and they are terrible headaches. And what you could see is at the beginning of the headache, there was vasoconstriction because they'd run out of nitric oxide and their artery was constricted. And then when they were in the most pain, the arteries were dilated in compensation for that. So in those earlier days, most people said, well, no, the problem with migraines are a vasodilation of the vessel. That's what hurts so much. But that occurs after the vasoconstriction. And there's been a great deal of work since those studies to corroborate that, and the role of estradiol depletion in leading to the constriction.
Can you talk about your groundbreaking research on pharmacoeconomics in terms of the cost of untreated vasomotor symptoms in women? Because I think that was really a landmark piece of work.
That's I'm glad you brought that up because what we did was, this relates to women age 45 to 55. What was prior to COVID, what had been reported in labor statistics, if you go back to 2016, 17, 18, what was reported was that there was an increase in numbers of women in the workforce in all those ages up until 2019. And then in not in 2019, until 2016, 2017. But there was a single group of women who hadn't increased, and 1 million of them had dropped out of the workforce. They were all age 45 to 55. Try to imagine that. So I don't think it's a coincidence that that's the time of menopause. So we'll try to look into the impact of severe hot flashes in women who go to work every day, women working for Fortune 500 companies. And we compared 242,000 women who go to work every day who had no hot flashes. Most of them had been given hormone replacement, versus women who went to work every day who had severe hot flashes. And we tracked, number one, the impact on their medical visits for a year's time, and the cost in medical care. Well, it turned out there was an excess cost for women excess medical care, a health care burden is a way to put it. The women with hot flashes had 1.1 million more visits in the year. They had health care costs that were over $300 million. And in addition to that, there was loss of work, days out of work. So altogether, when we got to the end of the database, these Fortune 500 company women, they cost $400 million versus in a year, versus the 240,000, 42,000 who had no hot flashes. Now, women in that age group should not have to put up with this. It's so easy whatever the mechanism to bring hot flashes under control, whether it's with hormones or hopefully with the new NDY treatments. And I think that needs much more attention. The importance, it's not only in preventing disease and controlling symptoms, but workability, creativity, productivity, quality of life. There are so many important issues just if you control hot flashes. Yet in listening to the program in New York City yesterday, caller after caller after caller was calling in saying, "Oh, I'm having 10 hot flashes a day. I didn't think there was anything you could do about it." I mean, it was what everybody was calling in about. I listened to the program for half an hour. That's how long it was on. And it was impressive to see how in this day and age, a problem that had been solved in the 70s and 80s and 90s up to the WHI publications now has become a problem. And it shouldn't be.
So, with all the major medical organizations, ACOG, North American Menopause Society, with leaders in women's health having access to these publications, you obviously still thought that there was an unmet need and the need to start advancing health after hysterectomy despite those organizations.
Well, remember that prior to the Women's Health Initiative 2002 report, after hysterectomy, 90% of women, over 90%, used estrogen replacement at some time. In the California Teachers Study, they have an outstanding finding. In that study, 97% of the women used estrogen.
Wow, 97.
They had no mortality from a heart attack. It's like the Framingham Heart Study, which showed that prior to the menopause, there were no deaths in women from a heart attack. It's only once they got post-menopause that their heart attack rate equaled that of the men. There is a real problem, and one of the things I think is important to know, there's a study called the ARIC study, the ARIC study, which looks at looks at patients admitted to hospital with an acute myocardial infarction. And the publication in Circulation, Aurora et al., the publication in Circulation just 2 years ago showed that what they reported was, and this is the word they use, a staggering increase in young women. This was women 55 and younger, being hospitalized for acute myocardial infarction. A problem we weren't seeing before everybody stopped using estrogen replacement. So we've got ourselves a major public health problem here that should be easy to address, but we have to raise awareness of it. The American Heart Association has come out with a position statement saying that in women who are under age 50, who are estrogen depleted, estrogen replacement should be considered, but certainly you should use whatever means you can to bring their hot flashes under control.
Yes, and we had a nice review article in the Cleveland Clinic Journal of Medicine, authored by Dr. Heather Hirsch and Tara Iyer, going over those updated guidelines and what it means from a gender-specific perspective.
That's a really important paper because what Hirsch and I point out is this American Heart Association position statement should impact on medical care. I mean, that's what we have associations for, is to give guidance. But I'm afraid it's very difficult. Once the fear was put in place, I have a slide I use in my lecturing which shows a zombie, and this calls zombie thinking, where such fear has been engendered because of the earlier WHI study. No matter what the WHI reporters say, I mean, they have reported very recently, over and over again, the women on estrogen had a reduced risk for breast cancer.
Yes, persisting into the 70s.
Right. And so that fear of breast cancer, which is so widely held, it just doesn't hold for women who used estrogen. They have a reduced risk. The data from Southwestern, which has been on now for 40 years, shows very clearly that women who've had breast cancer, who get treated with an aromatase inhibitor or with tamoxifen, Jordan is the inventor of tamoxifen, and he's the one who's come out loud and clear to say, no, once they've had 5 years of suppression of the breast cancer cells, any cells that are remaining, if you give the woman estrogen, it kills the breast cancer cells. There's a fantastic paper from Harvard which showed that breast cancer cells, they demonstrated 3,600 different actions of estrogen in breast cancer cells, the majority of which was to induce apoptosis, to kill the cell. Not many people know that, but it would be good for everyone to know that.
No, I agree. I have a number of breast cancer survivors in my practice, some who go on and have pregnancies with very high estrogen levels uneventfully, and those that do choose hormone therapy after they've completed their treatment, in conjunction with their oncologists and other physicians and considering all options.
This does get us to a subgroup of women who are often overlooked. It's estimated, and Kalnitz and Fobian wrote a recent paper about this. It's estimated that there are 200,000 women a year who have bilateral salpingo-oophorectomies. Most of these are being done because there's a history of breast cancer in the family, and they want to reduce their risk. But there are very good studies that show that if you do that, and these are all essentially women under age 45, if you do that and you don't replace the estrogen, you've increased their risk of dying of a heart attack, of developing severe osteoporosis, of, within 3 years of developing severe osteoporosis. And intervention, number one, prevents these diseases. So that's really an important concept. We don't use estrogen just for symptoms. We're using it to prevent osteoporosis, atherosclerosis, changes in the brain that lead to dementia, but reduces, even in these women who are carriers of the gene for breast cancer, using estrogen after oophorectomies reduces their risk for development of a breast cancer.
We'll be back after a quick break.
Have you ever experienced fitness failure? You set a goal to exercise, you're all excited, and then you're not. Hi, I'm Dave. I host the daily 10-minute podcast, Walking is Fitness. Instead of an exercise goal, I talk about making a fitness promise. And every day you keep that promise, you add another link to a growing fitness chain. This is a podcast of action. You'll create a fitness habit, which eventually becomes fitness momentum, and then on to all kinds of good stuff. Check it out. Walking is Fitness, and let's take a daily 10-minute walk together.
Yeah, that group of survivors and previvors, especially as we identify more ways of assessing people's genetic risk for cancers, my practice certainly has grown exponentially in this area. What do you do with the woman who can't or won't take estrogen, even if she's hysterectomized? What do you recommend?
Well, I think at top of the list is if she's having hot flashes, even if, a lot of women who have hot flashes don't know they're having hot flashes.
Right.
That's important. We did a study in Miami, 15 years ago, in which we were able to track hot flashes in a laboratory setting. And it's a large study, and so we had recordings of about 800 hot flash events. It was 40% of the women didn't even know they were having a hot flash when they were having one. The reason was a woman feels a hot flash when the blood flows into her skin and heats the skin, and temperature sensors in her skin tells her brain that she's got a hot flash. But if you start out in a climate where your skin temperature is around 35 degrees centigrade, to begin with, it can't heat any more than that. So you can see the phenomenon, the catecholamine effects, in a laboratory, but the woman isn't feeling it. So you can't just go by hot flashes. What I was going to say is, for the woman who's afraid of estrogen, the bottom line is get them under control. And you did discuss a number of ways. I think the new medications that are going to be available hold great promise for
Yes.
those women. I mean, as a professor of psychiatry, I can say when someone is terrified of taking something, that's a state that they are in, and you have to work with them around finding a solution that where they don't feel threatened every minute of every day. So the alternatives become important. Paroxetine was mentioned in your previous discussion, and that's a viable alternative. But the primary thing for that woman is to help her control her hot flashes. The next most important, I think, has to do with sex. And
Yes.
it has to do with the loss of vaginal cells, the loss of vulvar cells, the shrinking of the clitoris, the Bartholin gland stops secreting. In the plateau phase of sex response, when a woman is responding normally, she secretes from her Bartholin gland and lubricates the entire vaginal opening. Well, Bartholin glands, I can tell you because I've written a paper about that and we studied it, they're replete with estradiol receptors. Without it, they shrink and atrophy just as the vagina and the labia and the clitoris shrink. Women then will still go on and have intercourse that's painful. The first thing a doctor can do is to say to a woman, stop having any pain with penetration. I can't help you if you will continue to do that. Usually the partner, if he's there, or if it's a female partner, if she's there, will agree. She says, I don't want to hurt you, and you've got to tell me if I'm touching you in a way that's hurtful. So from a psychiatry point of view, step one is stop pain. Don't stop relating in ways that are affectionate, that are erotic, that are stimulating. That's good. That's very healthy for the vagina and for the vulva. Because, let's say you respond from having your neck touched. We once worked with a woman. Remember, at the Yale Sex Counseling Program, over 40 years, my wife and I saw 10,000 individual people.
Wow.
So our database is very large. But I once worked with a couple where the woman would regularly have an orgasm from the stroking of the left side of her neck. Nothing on the right side, nothing anywhere else in her body. Her body was attuned to her left neck. Well, what we know is the body is capable of an erotic response almost anywhere. So finding that and knowing there's not going to be any pain with penetration, that opens the door to restoring normal function. And then there's a whole set of steps that can be taken. Sometimes someone who is reluctant to take estrogen will agree to using some locally in the vagina. There are so many different products available that can restore the health of the vagina. That should be a high priority. Forget about the male partner, just for the woman's sense of being a woman, of feeling I'm me, I'm the person I was most comfortable with all my life. I feel alive again. I can't tell you how many times patients have come back and said, and that's been my endpoint, by the way, in giving care, is to say, you've treated your patient adequately when she comes back and says, I feel like myself again.
Yeah, that's a great feeling. Kind of a flip perspective, when I talk to women about genital health, sometimes I like to divorce the vagina from sex, as strange as that sounds, because I have so many women who stop therapy because they're not sexually active. And I tell them, we don't care what you do with your genitals or if you're doing anything with whomever you're doing it with, but we want healthy tissue, because if your vagina and vulva is atrophied and dry and at the wrong pH and a bad microbiome, that affects your bladder. And we all need bladders that function. So I think that's a common misperception among women, especially if they are putting something in their vagina, that it's just for sex. And it's great if it helps sex and sex is back to their usual self, but it's far, beyond that from a body integrity standpoint. I just want to wrap up with one last clinical scenario that I see a lot, because AHA focuses primarily on the under 60 woman. But lots of women in my practice and people that are referred are people who had hysterectomies years ago. They've been on estrogen for years. They're 65, 75, 85. I have some in their 90s, and their physicians keep trying to take away their estrogen, and they continue to have hot flashes, and or they continue to feel better on estrogen, and they're having the darndest time getting prescriptions.
So I do have some experience with that in our Yale study of women who'd had a stroke. There were 652 women in the study, so 326 in each arm, with half getting estrogen replacement and half getting placebo. And the women were in a study for the average of 2.5 years. 400 of the women, more than 400, were over the age of 80 when we randomized them into the trial. The oldest
Wow.
woman we randomized was 92 years old, and she completed it at age 95 or 6. What we learned was a tremendous amount of the importance of estrogen in that age group. And remember, we were using a relatively low dose. It was a milligram. We had argued about a half milligram, and I said, let's go with a milligram. I didn't realize our population was going to be that much older, because remember, we were trying to prevent a second stroke. Now, what we did find was that getting estrogen, as long as the women took it as prescribed, we had very meticulous data about compliance, because the women were given 90 pills in a bottle, and every time they opened the bottle, it was recorded electronically. So every 3 months, I got a recording. And what happened was that what we found was the women who were randomized to estrogen, estradiol, who took 80% or more of their pills. There was no difference in the this is all in the New England Journal, so it's easily accessible. The women who took the estrogen as prescribed, they did not have any increase in having a second stroke. What they did have was improvement in cognitive function. That was really important, because we had baseline and 6-month, 12-month, 18-month, and 24-month measures of cognitive function. And what we were able to demonstrate is, even in these elderly women, the average age of the women randomized to the trial was 73. But even in these women, taking estrogen daily slowed the rate of cognitive decline. That was really important. But here again, we all have wonderful examples of women in their 80s and 90s. And my oldest patient, whose name was Abigail, was a concert pianist, a Juilliard graduate, and she couldn't play because of her small joint pain. Remember that the membranes that surround the bones in your fingers produce their secretion in response to estradiol. So lubrication of those joints is a big deal. She couldn't play anymore because of joint pain. My mother, who was her friend, convinced her. My mother said, my life has been saved by wearing an estrogen patch. My mother's life was playing bridge, so she could remain a bridge champion as long as she used the estrogen. But what happened in Abigail's case was, within 2 weeks of getting estrogen replaced, she started to play again. And then she gave a concert in the place where she and my mother were living, an assisted living place. And she played the piano for an hour from memory. And that's how they celebrated her 100th birthday.
Oh, what a wonderful story. That is just so heartwarming.
I don't want to hear about stopping women's estrogen when they're in that age group. Over and over again, the women who are using it will tell you, whether it's urinary control, continuing sexual function, don't knock people in their 80s about, that don't ignore that they have a sex life. They do. They can.
Oh, I don't.
But certainly my mother continued until her 90s to prevent osteoporosis from progressing, and she did. So you can stop it in its tracks. You can't make it go away, but you can stop it from getting to the point where the bones start falling apart all over the place. There are lots of indications: urogenital, mood, everyday function, and of course the bone loss. What WHI showed us was once you get into the 70s and 80s, the atherosclerosis, if it's going to occur, is there.
So the timing of starting estrogen is very important, and certainly the indications and reevaluating it. But I agree that the medical profession, people that are serving our patients, we should not be ageist or sexist, and you have to individually look at it. Certainly there's labeling of an increased risk of dementia in women over 65, an increased risk of stroke. But like I tell my trainees, that has to do with when they start and is there existing disease. So if you started hormones before that, within 10 years of menopause, and you just happen to have more birthdays, you might need to reduce the dose because of changes in metabolism. You might need to go to transdermal to reduce the risk of clot or stroke. But you don't have to summarily stop based on age. And I think that's a really important learning point. But I really want to thank you, Dr. Phil Sarrel, for joining us in the Sunflower House on this special CME edition of Speaking of Women's Health. It was great talking to you about advancing health after hysterectomy and using estrogen in women for both symptom control, prevention, and prolongation of life. And I encourage all of our listeners, physicians, APPs, physician assistants, pharmacists, please go to menopauselearning.com and claim your CME, and you can get links to these references and some of these lectures that we've been discussing and information about more upcoming podcasts. So I'm your host, Dr. Holly Thacker, the Executive Director of Speaking of Women's Health. And thanks so much for joining us. Please subscribe to our Speaking of Women's Health podcast. Know that this is not medical advice. Please see your own healthcare professional. I'd like to thank our Executive Director, Lee Kleckar. And you can sign up or get our podcast anywhere you get podcasts: Apple iTunes, Google Podcasts, Stitcher, iHeartRadio. Thanks so much. Bye-bye.